All right, we're going to get started. Thank you, everybody, for making it. I kind of love the spread in this room. It's going to be cozy. Feel free to come forward if you want to, or loiter in the back, which is probably what I would do. I am Jessica Wall. I am an emergency medicine physician and peds emergency medicine physician in Seattle, and we have Maggie Samuels-Callow with us and Nicole Nadeau. We are a group of peds EM physicians that like to talk about the literature in the pediatric world as it extrapolates to the emergency medicine world. So we're going to talk with you today about hot off the presses, a handful of synopsis of the best new papers in pediatric emergency medicine. And we'll let Maggie get started.
Great. And because we have trouble focusing, we're going to go through a ton of papers really quickly in the next 20 minutes. I'm going to start with this one because it comes up all the time. So thinking about what do you do with a torus fracture or a buckle fracture of the wrist in kids. And they did a randomized controlled trial of children aged 4 to 15 years across 23 hospitals in the United Kingdom. And they randomized them 1-to-1 to an offer of a bandage, which is basically an ACE wrap, versus rigid immobilization or splint. It was an unmasked trial because it's really hard to blind people to what they've got on their wrist. And they excluded folks who had multiple injuries, delayed presentation, or couldn't complete follow-up. And the primary outcome was the child's pain at 3 days, and they completed the appropriate intention to treat and per protocol analyses. Lots of children in this study, 965, randomized to bandage and rigid immobilization, and they had primary outcome data for 94% of them, and they found that the pain was equivalent at 3 days. There was no group differences in pain or function, even at 6 weeks of follow-up. And you can see that in this chart as well, where you see that that's crossing the line of equivalence, crossing the equivalence margin, both in the intention to treat and the per protocol analyses across all age ranges. So what are the take-home points here? The first is that families are willing to take part in this kind of study in the emergency department. They seemed to have some preference for rigid immobilization in their secondary analyses. Even though they were unable to mask, they still found equivalence between these two strategies. And really, as we think about the implications for our clinical practice, that shared decision-making and immediate discharge with one of these two strategies is likely safe and effective. So moving on to the next paper, looking at umpholitis and concurrent serious bacterial infection. So this paper used the PEM-CRC, which is a network of academic pediatric sites, 28 sites looking at infants less than 90 days of age with umpholitis seen in the emergency department during a prolonged period of time, 2008 to 2017, because it's a relatively rare condition, so they needed a long period to ascertain what was going on with them. And they looked at demographic, clinical, laboratory, treatment, and outcome data. And importantly, among these infants, the 566 that were in the cohort, the vast majority of them were well appearing, so that's 95% of them. 11% of them had fever at home when they were in the emergency department, and cultures were obtained in a little over half of them, and of those, 85% of them grew a pathogen, and you can see here what the most common ones were. The vast majority of these children ended up being hospitalized, only 16% requiring an ICU. But what you'll see is that a very small number of them had serious infections. Only 2.1% had sepsis or shock, and only 0.4% had severe cellulitis or necrotizing soft tissue infection, and there was only one death. And the point I really want to emphasize here is that all of these serious complications occurred only in infants less than 28 days of age who would have gotten a complete sepsis workup per protocol anyway. So what we learned from this study is that mild localized disease was typical of umpholitis, that serious bacterial infections and adverse outcomes were uncommon, and routine testing may be unnecessary in well-appearing afebrile infants with umpholitis, but you should have caution in those who present with fever or those who are less than 28 days of age. The last paper I'm going to review is the reassessment of the role of race in calculating the risk for urinary tract infection. You've probably seen that folks have been reevaluating the role of race in many of our clinical algorithms, including GFR calculation, as we increasingly recognize race as a social construct rather than a biological variable. However, race had been included in the UTI prediction algorithm in pediatrics for many years. So the goal of this study was to try and understand what is the optimal prediction rule for predicting UTI in the absence of including race. So they used a systematic literature review and had 2 independent reviewers assess studies for risk of bias and abstracted data and pooled the odds ratios and used meta-regression. Ultimately, they had 16 studies, and they did find that the pooled odds ratio of UTI among non-Black children was significantly higher than among Black children. However, replacing race with history of UTI and duration of fever resulted in a model with similar accuracy, sensitivity, specificity, and area under the receiver operating curve to our old model. So ultimately, we learned that the new UTI decision rule is equally accurate, and we need to think about race-conscious medicine, where we think about how race can be a proxy for other factors and how these factors should be considered for inclusion in our decision-making process. But ultimately, the association between race and UTIs, observed in many studies, including this one, still requires explanation and additional research.
All right, good morning. So our next study comes to us from JAMA Pediatrics and looks at the association of early oseltamivir, the drug we all love to hate, with outcomes in pediatric patients hospitalized with influenza. This is a multi-center retrospective study done at 36 sites. It included about 56,000 patients under the age of 18 with a median age of 3.6 years. And it occurred over a period of approximately 13 years. And what it did was compare the outcomes of those with early receipt of oseltamivir, defined as initiated within hospital days 0 to 1, to those without. So you can see from the results from the forest plot below that all outcomes favored early oseltamivir as opposed to late or no oseltamivir, including length of stay, 7-day readmission rate, late ICU transfer rate, and rate of mortality and ECMO support receipt. So our take-home points here are that early oseltamivir truly does seem to show benefit in pediatric patients hospitalized with influenza. And it may be worth considering initiating it in the ED, particularly if you're in a site with prolonged boarding or transfer times, to ensure early receipt. The next study is a clinical practice guideline revision from the American Academy of Pediatrics, specifically regarding the management of hyperbilirubinemia in late preterm and term infants. This was an expert committee that gathered and reviewed all new available literature since 2004, which was the time of the prior guideline revision. And with this, 25 key action statements were created. Of these action statements, really 3, I think, are most pertinent for us as emergency medicine physicians to have some awareness of. The first is to remember to check a direct bilirubin in addition to total in any formula-fed infant with ongoing jaundice at or after 2 weeks, or any breastfed infant with ongoing jaundice at or after 4 weeks. The reason behind this being that in checking that direct bilirubin level, we may detect biliary atresia within the critical time window during which they can have surgical intervention prior to them having to go on to transplant potentially unnecessarily. So infrequent but powerful. Key action statement number 2 that's most pertinent to us in emergency medicine is just for us to be aware that there are new nomograms, and they show that infants can be safely managed with higher thresholds for phototherapy. So as this sort of catches on, you may see a discrepancy in sort of infants being referred in for phototherapy, but in fact, if you consult any nomograms, they perhaps may not need it yet, as this sort of disseminates throughout the community. And then 3, really importantly, this is sort of a new concept within this guideline that wasn't there previously, is in addition to the prior nomograms of levels requiring phototherapy or levels requiring exchange transfusion, there now are new escalation of care levels that are meant to serve as indicators of need to a center with a higher level of care before reaching those critical exchange transfusion levels. So essentially establishing a bit of a sort of warning or danger zone to say if you're anywhere in that zone where exchange transfusion could be a possibility, let's get you to the right center of care where they could achieve that in a timely manner, given that time is certainly brain here with the risk of chronic duress. And while awaiting that transport, of course, emergent intensive phototherapy and IV fluid should be initiated. So our take-home points here, really, one is just awareness. Just be aware, sort of throw out any old bilirubin nomograms that you've got stored in your phone or in whatever your sort of handy guide is. And do make certain that the online tool that you're using is updated. I can tell you that some of them are not yet. I checked as recently as last week. Try not to forget the direct bilirubin, as it can truly be quite impactful for that patient. And then just be aware of the existence of proactive escalation thresholds at which transfer to a center capable of exchange transfusion would be prudent.
Her point about the app, super important. I realized after we reviewed this that all of my apps on my phone for Billy calculation are actually old and incorrect, so double check them. So we're gonna finish out talking about neonates, because They're terrifying in the emergency department, and neonatal airways are also terrifying in the emergency department. And there's some new literature that's come out that I think supports some of the ways that we practice and some of the ways that we can think about management of these patients. So our first paper, supraglottic airways compared with face masks for neonatal resuscitation. This is a systematic review. It was published in September 2022 in Pediatrics. This paper, so this was actually a systematic review meta-analysis that was conducted by ILCOR. The Neonatal Advanced Life Support Task Force looked specifically at airway management, and they pick a kind of a topic every 5 years. So their topic this time, again, face mask versus supraglottic airway. So things that we like, we know, iGels, King Airways, more for adults and children, LMAs being the most common they used here. Their population was looking at newborn infants greater or equal to 34 weeks that received intermittent positive pressure ventilation immediately after birth. So that initial resuscitative period. Their intervention was the supraglottic airway. The control group was a face mask. The primary outcome was failure to improve. And failure to improve is defined by things such as heart rate not improving, saturation not improving, perfusion not improving. And then they also looked at secondary outcomes where they broke those down specifically into the need for compressions, heart rate that remained less than 100, need for intubation. They were able to collect 6 randomized controlled trials that fit their criteria. And they ultimately had a little over 1,800, I believe it was 1,823 patients that were included in this meta-analysis. Looking at their primary outcome, which again, so they're looking supraglottic airway versus face mask, and their primary outcome is failure to improve with the device, so needing to move on to something else, and or having just failure with decreasing vital signs. And this showed that through their meta-analysis, it was statistically significant to favor supraglottic airways. Supraglottic airways resulted in a reduction in the failure to improve. On their secondary analysis, supraglottic airways also demonstrated a reduced need for intubation. Both of these favor using a supraglottic airway in the initial neonatal resuscitation for a patient greater than 34 weeks. And as we all know, neonatal intubation is somewhat of a difficult skill. It is a very, very small airway and requires specialized equipment and technique. So in conclusion from this paper, in a late preterm infant that you are trying to manage, it may be reasonable to use a supraglottic airway for positive pressure ventilation as opposed to a face mask. This can be extrapolated further by prior studies, which also showed a similar benefit of supraglottic airways over intubation in the initial resuscitation period. Now, for those patients that are little that you are going to intubate, this is a paper that was published in the Journal of Perinatology in February of this year. This is the Association of Full Premedication for Tracheal Intubation Outcomes in the Neonatal ICU, compared an observational study. This was a study that was done, it's a prospective observational cohort study. It was done at a single center that is part of the NEARS for NEOs registry. For those that don't do a lot of NICU research, NEARS for NEOs is a large registry that looks at neonatal airways across the country. This study looked at all DICU intubations from 2017 to 2021. And essentially what they did is there was a change in the structure of intubation within that ICU during that time. They basically rolled out a checklist for their medications. And so they did an observational study looking at how this changed outcomes for their intubations. They compared tracheal intubation with what they called full medication, meaning an opiate, either fentanyl or morphine, a vagolytic, which is atropine, and a paralytic, which in this study was rocuronium with the exception of one case where they used vacuronium. They then looked at tracheal intubation with just partial, which was 1 or 2 of those medications, but not all 3. And typically those 1 or 2 medications was either the vagolytic or the vagolytic plus the opiate. There was only one where it was a paralytic that didn't have full medication. And then they compared these to intubation with no premedication. The outcomes was presence of tracheal intubation associated events, which for NEARS for NEOs is a very specific list of events that they look at. So they have very well-defined criteria for both severe tracheal intubation adverse events and then what they call non-severe adverse events. I always like to point out that things like cardiac chest compressions for less than a minute is in the non-severe category. But if you look at the severe category, you have things like esophageal intubation that has a delayed recognition, cardiac arrest where the patient did survive but had prolonged resuscitation. So fairly significant events. When they compared this, they had a total of 352 intubations that were included in this study. Now, when they looked at the demographics of their different cohorts that were included, it was significantly significant that they had a few more intubations with medications in patients that weren't in the newborn and just delivered. So not within the perinatal state, but were several weeks out, but still in the NICU. So this data is a little confounded by them not being the exact same comparison groups. That being said, what they showed was when they're looking at any adverse event, so again, severe and non-severe, that it favored full pre-medication. It was actually statistically significant, full versus partial and full versus no pre-medication, showing that they had a reduction in adverse events, any all-comers, in this group. They also did subgroup analyses looking at secondary outcomes, and the one I find most interesting is the first attempt intubation success, because that's something we tend to focus on for outcomes of patients. And they did show full versus partial medication, that full was statistically significant and better than partial. However, when you have partial versus no pre-medication or full versus partial, neither of those crossed the threshold for significance. So the take home from this study is neonatal intubation with full pre-medication, meaning an opiate, a vagolytic, aka atropine, and a paralytic, when compared to partial or no pre-medication, reduces adverse events and probably improves first pass success in the NICU. Now, this may not be ready for prime time in the emergency department. We have a very different population, either the baby delivered in front of us or the baby that has gone home and come back to us and is quite ill. And that's not the same population that lives in the NICU. But this is something to pay attention to when you're thinking about setting up resuscitation protocols for this population in your emergency department. All right, you've survived us. Do you have questions about any of the studies that we talked about? Yes, a question, I love it.
I have a general question, not about the study, but about pediatric EM, which I work in the community a lot of hospitals. We see kids, we don't admit kids. My Achilles heel are these under 28-day kids that come in with a cough. Mom said, have fever at home, but does not have a fever in the ER. Baby looks great, and like sitting at home is sick with, one of the many upper respiratory.
Yeah.
And I called up to transfer and the children were like, yep, you have to transfer them. They're under 28 days. And
It's like we planted you. We actually presented that last year. I'm going to let Nicole talk about it. No, you're great.
and, then it's like, I don't feel real comfortable AMAing them. They don't want to be transferred to pediatric hospital. So usually I call the pediatrician. They can see the kid tomorrow. And like a lot of them don't have fever. It's like,
Yeah.
It's my Achilles heel because to do a full septic workup on these totally well-appearing infants that don't actually have a fever in the ER, it seems so overboard. If they have a fever, they don't look good or not feeding, but I'm talking about like breastfeeding, look good, vigorous, happy. They have just this little cough that their sister has who's 5. It seems so overboard to do the septic workup.
Yeah, so I think this, remains an ongoing area of consternation and challenge. I think certainly it's an area where the pendulum is swinging, and I think has swung very meaningfully in the last even, 5-10 years towards less conservative. I do think it's challenging, though, particularly the specific population that you're saying in the sort of under 28 days. So certainly the new AAP, newish AAP guidelines do allow for some risk stratification now in the 22 to 28 day old. So that has been a significant change and is worth sort of taking a, I'm sure you're familiar, but worth always sort of visiting those patients. So they have some role for risk stratification with labs and the potential to be discharged home if, officially per the guidelines, if certain things are sort of within parameters. I think it's the case of the younger infant and with such strong suspicion for viral illness is hard. I think the guideline does start with like fever without a source. So if you're going to, people try to sort of really confidently assign, I think the source is the virus. That said, I find it challenging. An enormous expert consensus just came together and finally did make a new guideline for the first time in 50 years, and they intentionally left out of their branching logic positive for RSV, right, or positive for paraflu or whatever the case may be. And especially in those younger infants, while it's overwhelmingly likely that it is that viral illness, even with like a true positive viral swab, not even just a sick contact at home, not even just like a little cough or congestion. While the rates are significantly less, perhaps even halved, they're not negligible. And it's hard. I mean, the outcome is, potentially, death, disability. And so I think it's hard. Within the sort of context of the AAP document, they did not put it anywhere in their algorithms, and that was a very intentional decision. The spirit of the whole thing is shared decision-making. Like, that is plastered throughout all of the text of this very long guideline. I would say less so in those under 22 days. I do think they're pretty clear about a pretty full court press there. But overall, the spirit of it is talking about the data, talking about, engaging in shared decision-making with the parents. And so there is a little bit more wiggle room, but they did not build in viral positivity to those algorithms, and that has been intentional. So it remains a tough spot. I'm very happy to now sort of have these official parameters by which we can risk stratify anybody 22 days and older, and I happily do that. But I find it difficult to discharge fully if it's against the guidelines. That said, one sort of in-between option can sometimes be that you do the full workup and antibiotics if they really won't consent to transfer, and your goal is to try to make sure you're keeping the infant safe and ensure that follow-up with a great call to the pediatrician, like you said. No perfect answer, but hopefully that's at all helpful.
So if they're over, there's a 28-day, and they do the biofire, they do have coronavirus. So you do have a confirmatory, you still think it's going to get it, like, I mean,
Yeah. So.
you know what the fever is if they have one?
Yeah. So I think the trouble is. Yeah, so I think the trouble, again, the rates are less, but definitely not zero. And the trouble, like for instance, rhinovirus in particular can stay positive on a PCR for 3 weeks. So the older they get, the more is that positive PCR the cold that they and their sibling had 2 weeks ago, or is that the active source of fever? But again, this is shared decision making with the parents and talking about how it decreases the risk, but not zero. Oftentimes, though, they may still be able to, if you just do blood and urine, especially over after the 29-day mark, they may very well be able to risk stratify out of LP, out of antibiotics, and out of admission by the new guidelines. So,
And that's the most common workup that we end up doing, quite frankly, is going to be blood and urine, and then those will end up, hopefully, ultimately being negative. And then to your point, it's viral and they go home, but it is not a negligible risk, which is why they still have that screening.
And sorry, one more though. What about if the mom says they have a fever, at the ER they do not have?
those are equivalent. So fever in the ER or measured fever at home truly are equivalent.
Yep.
Great. Any other questions on
other
any topic?
questions? Thank you all very much for joining us. We appreciate your time.